Hello, everyone, and welcome to Grand Rounds. We're honored today to have Dr. Rulan Parekh present the 10th Annual Demetrius Ellis Lecture. As a reminder for those attending virtually, questions can be posted in the Q&A throughout the lecture, and you can join us for a more informal meet and greet at the end of the presentation by asking the host to unmute you. The CME and maintenance of certification codes will be posted in the chat and displayed in the back of Rangos. So Demetrius emigrated from Greece to the United States at the age of 13 and went on to realize the American dream by becoming a pediatrician. He completed his residency at Children's Hospital of Pittsburgh and then returned to Pittsburgh after his fellowship to really start the pediatric nephrology division here in 1977. Sort of in true fashion, he taught students and residents, looked after all of the children with diverse kidney disorders in our entire region, while also carrying out clinical and laboratory-based research. His clinical expertise is well recognized, particularly in the field of pediatric kidney transplantation. His patients were the very first children with kidney transplants to receive cyclosporin or tacrolimus for immunosuppression, and superior outcomes have distinguished children as amongst the top pediatric renal transplant programs. Dr. Ellis was awarded the 2011 Howard Mermelstein MD Award for Excellence in Pediatrics. He's also engaged in high-quality research with more than 100 peer-reviewed studies and 28 book chapters. He served as the PASS Center Principal Investigator for the North American Pediatric Renal Transplant Cooperative Study and was a co-investigator on the epidemiology of diabetes complications, a longitudinal NIH-sponsored study here at Pittsburgh. He officially retired in 2017, having given 40 years of service to the children in our region. And in celebration of Dr. Demetrius Ellis' realizing the American dream through the service of child health, we honor him today with this lecture series. I'm pleased today to welcome Dr. Rulan Parekh, who is Vice President Academics at Women's College Hospital, Staff Nephrologist at Women's College Hospital and Hospital for Sick Children, Professor of Pediatrics and Medicine in the Departments of Medicine, Pediatrics, Epidemiology, and Health Policy and Management Evaluation at the University of Toronto. Dr. Rulan Parekh is the consummate clinician scientist and an international leader in clinical epidemiology and translational research in kidney disease. Her work has revealed novel genetic risk factors leading to kidney disease and increased risk of cardiovascular morbidity and mortality for children and adults with kidney disease. Since 2000, Dr. Parekh has maintained a record of sustained NIH and Canadian Institutes of Health research funding. She has significant productivity with more than 175 published manuscripts and a stellar track record of mentoring students and postdoctoral trainees. She's received numerous awards, too many to enumerate here today, including the NKF Maryland Award, John Hopkins Bloomberg School of Public Health Mentoring Award, and was elected into academic honor societies such as the American Society for Clinical Investigation. Dr. Parekh now holds the FM Hill Chair in Health System Solutions at the University of Toronto. Please join me in welcoming Dr. Rulan Parekh for today's talk.
Thank you so much. Am I able to show my slides now?
Yes.
Thank you. There we go. Are you able to see the display slide or the main slide?
You can see the main slide.
Okay, great. Thank you very much. Thank you so much for having me. In fact, I've been to Pittsburgh before and got to visit you all. And in fact, it's a great honor to be asked to come again, and hopefully I'll get to visit you in person soon. I used to know Dr. Allison. In fact, I met him when I was just a fellow. And I will say he was quite a noble pediatrician, and I really enjoyed meeting with him. And one of the things that I still remember was how encouraging he was of women in research, but also really encouraging women in nephrology, and was great to me when I first met him. So it's a great honor to be here. So thank you so much for having me. So just to tell you my disclosures. And then I'm going to start with a case just to help sort of set the stage of what we should think about. And so this is a pretty typical case of a 16-year-old who presents with edema and hypertension. They have an elevated creatinine, and when you measure their estimated glomerular filtration, sorry, that got cut off, their kidney function is about 80%, let's say 80 mils per minute per 1.73 meters squared. They have nephrotic range proteinuria, and they have an elevated blood pressure, 145/85. And the biopsy shows what is sometimes not unexpected when you take a look at the kidney itself. This is a normal glomerulus. You're taking a look at the blood vessels as they enter into the glomerulus. And then what you're taking a look at when you see FSGS is within the glomerulus, you'll have some scar tissue and scarring that occurs within parts of it called focal segmental glomerular sclerosis. And that leads to scarring within the kidney and spilling of protein, and ultimately then potentially progression to end-stage renal disease. Often this is treated initially with steroids because it can be responsive, then tacrolimus to ultimately maintain remission. And sometimes we use renin-angiotensin blockade, and also sometimes you may treat with a statin. So often our patients and the families ask, like, what caused me to get kidney disease and FSGS? What are my risk factors for progression of kidney disease? And we often think about the disease and the hypertension and the hyperlipidemia, the medication, potentially ethnicity, other social determinants of health. And is there medication to treat my disease? And is there treatment to prevent progression to end-stage kidney disease? So as we think about nephrotic syndrome when it presents in children, I think it's important to note that in the 1930s, actually, even before that, prior to the 1930s, the mortality rate was extremely high. Once sulfonamide started being used in the 1930s, that the mortality rate was able to drop, and children actually did much better. And then ultimately, when you were able to treat the nephrotic syndrome with peritonitis with penicillin, you were able to then again treat the patients and try and lower the mortality rate. But it wasn't until the 1950s that steroids were actually used, initially ACTH and cortisone. And that's when it was noted that there was a significant decrease in the mortality rate. And then studies done in the 1950s, 1957, which I'll show you, ultimately showed that there was evidence of significant improvement in mortality, and using other immunosuppressives like cyclophosphamide and CNIs, you could actually see that the mortality rate actually dropped to zero. And now rarely, at least within North America and Europe, do we actually see any mortality from nephrotic syndrome. So this was the initial study done in 1957. And I think the point that I want to make today is we're 60 years on, but we haven't changed that much in what we've been able to do in terms of nephrotic syndrome. And so it's important to note that there's a lot of still work that we still need to do. And it's kind of sad that in the sort of 80 years that we really haven't gone very far. But my hope is to show you what we've done so far today. So typically what we do when we see patients like this is that we think one size fits all. You can give them a therapy, some have an adverse event, some have no benefit, some have benefit. And the hope is that in general, you think you know what causes the disease, and you're actually able to give them a treatment, and then they go on and do well. What we've done in nephrotic syndrome is that since the 1950s said, well, let's give them steroids, and we can give them and decide if they're steroid sensitive or steroid resistant. And this is sort of the simple paradigm that we still use today, and it helps sort of do all the prognosis that we tell families and we talk about. The problem is that there's a lot of variability. I don't expect you to read the slide, but it's more to show you that there's a ton of variability in how you give the steroids, how you go every other day, what's the dose, what's the duration, what do you treat for relapses. And really, early studies showed that there was longer courses were better, but the studies weren't done that well. And recent RCTs have shown that extended treatment with steroids haven't really had an impact. What we also know is that when you try and take the dose or duration, you make adjustments in it. Again, it really doesn't change that much. Steroids are good for you. Steroids actually treat the underlying disease. But really beyond how much you treat, we really haven't gotten that far in trying to maximize what we can do in terms of our patient outcomes. And so what I try to propose to people is, we've taken this one size fits all, but especially in pediatrics, and I think specifically in kidney disease, which is quite rare, is that we should really think about how are patients grouped by disease subtypes, risk profiles, demographics, socioeconomic factors, clinical features, biomarkers, subpopulations, because really the question is, are really all of us exactly the same? And so we treat 100% of patients coming in with nephrotic syndrome with steroids. They don't all respond, or they may respond at variable rates. But does that not really explain that perhaps the patient groups may benefit from different target therapy? And maybe there are these subendotypes that we need to think about. And so when we talk about the pathogenesis of nephrotic syndrome, we actually don't really know what causes nephrotic syndrome yet, and haven't known this whole time. And I think one of the things that we've worked out is there clearly are genetic disorders that occur. So if you take the kidney, again, you're looking at the nephron, you then go to the glomerulus, just like I showed you in the earlier picture. And when you look within the glomerulus itself and you cut one of those vessels, What you're actually seeing here is within the capillary itself that you see a podocyte that sits on top of it. And what we as nephrologists love is that with this really interesting cell, with the interdigitation, you're able to maintain the slit diaphragm. And basically any proteins within this area or within the slit diaphragm that are affected can lead to sort of abnormal proteins that cause disruption in the slit diaphragm, disruption in these tight junctions that occur, and therefore you spill, like a spaghetti colander, you're going to spill protein and blood within your urine. But what we also recognize is that there's a lot of variability that occurs. So what are we missing? We're missing that between children, there's a lot of inter-individual variability. Is that related to some genetic host features? Is it that there's actually these endophenotypes that in fact we just clustered everything in nephrotic syndrome as one bucket, but in fact there are multiple things that lead to the same phenotype? And are there actually drug responses that are different, B cell, T cell, or both, that are suppressive, but maybe we need to think about it a little bit differently? And why steroids work is steroids affect your B cell and your T cell immunity, both of them. And so we're just doing the shotgun therapy. So maybe we need to think through how can we tease out these differences. And so when you take a look at children who present with nephrotic syndrome, 90% of them have steroid sensitive nephrotic syndrome. Out of the 90%, 65% are going to have infrequent relapsing. 35% go on and frequently relapse. This is the group mostly in the US that you're following because they're referred then to pediatric nephrology. And so what we see as nephrologists tends to be this group. But it's important to recognize that there's this group that actually, the 25% of them never relapse again. And so, 40% go on and relapse just a couple of times. So is this disease the same as this disease? And we clearly know that this separation of steroid resistant is that some of them still respond to medications. So maybe part of this group should actually be over here. And then some of them do have genetic causes. So I think the point I'm trying to make with this slide is it's really interesting as you start trying to differentiate these different groups. Perhaps this is how we can actually start thinking about the molecular phenotypes or these endophenotypes. It's important to note also that when you take a look at medications and say, well, can we tease it out by medications and say there's differences if you're giving cyclophosphamide versus an anti-B cell only and rituximab versus a calcineurin inhibitor versus MMF versus a calcineurin inhibitor. I think what's important to note is that it's very hard for all our studies because we sort of mix and match a little bit. We're not doing apples to oranges maybe, or a Macintosh to a Fuji apple maybe. And so we're not always comparing directly to be able to say, perhaps if we understood the drug itself and how it was causing the immunosuppression, perhaps it would help us identify which children could actually respond. And so there's clearly more work that we need to be doing, I think, here with medication, because some children do great with rituximab, but some children also do greatly with cyclophosphamide. And are they actually affecting the same mechanism? And we have to understand that a little bit further. So I'm going to focus now on steroid sensitive nephrotic syndrome because I think this has actually been the area that has not been as well studied. And so a recent meta-analysis that took a number of studies, including one that we did here in Toronto, actually pulled the incidence and said that it was about 2.9 cases per 100,000 children per year. But it's important to note that there's a much higher incidence within sub-Saharan Africa, as well as within Asia. And it's really important to recognize that there are significant gaps of areas that we just don't have any idea. And so we really need to understand further also what happens in South America. But we really think that overall, the incidence rate is relatively low, so it's quite a rare disease. The pool risk of relapse was 72%. But again, what was interesting is that if you take our study population, which I gave you those numbers before, it clearly varies because our populations in pediatric nephrology papers seen by nephrologists are the type of patients who do relapse a lot. So we don't really take a look at the patients who've gone straight to the pediatricians and be managed by them and take the whole gamut of all the children who have nephrotic syndrome. What's interesting is the study I'll show you in Insight, which is what I've run here in Toronto. Our incidence has actually increased over time based on the population, and we actually have a 6 times higher incidence among the South Asians. So we also did a comparison just to say, well, let's take a look at incidence of nephrotic syndrome sort of across by ethnicity in different places. And you can see, in fact, it varies quite dramatically, with the South Asians pretty consistently having a higher incidence rate. You can also see within the types of disease that you have steroid sensitive or steroid resistant. Again, the majority of disease is steroid sensitive, which is good. So I think that's pretty consistent. Steroid resistance can also vary a little bit and vary by country, which we need to understand a little bit further. And so I started this study back when I first came from Hopkins to Toronto in about 2010. And it was really to understand how can we prospectively follow children at the time that they present with nephrotic syndrome. So not just when they come to nephrology clinic, but as if you would come to the emergency room or a general pediatrician or your family physician and were diagnosed with nephrotic syndrome. What's the sequelae that happens afterwards? And can we start trying to identify predictions at the time that you present? And one of the main things we found initially was really the ethnic differences in incidence and outcomes. And I thought that this was really important because we were able to take Stats Canada and really compare within the city of Toronto our populations that are of European, South Asian, East, Southeast Asian descent. And we were able to take a look at the incidence for the population that we saw over time and then do comparisons. And what was amazing was the South Asians always had a higher risk. Here the population was relatively small, so we couldn't say much here. But as the population was getting bigger, we saw that there was a 6 times higher incidence of nephrotic syndrome among South Asian children. And these South Asian children weren't necessarily born outside of Canada, but the majority of them were actually born in Canada. So these are recent immigrants, this is first generation. And so clearly there's something, if the incidence is much higher in the population, perhaps that indicates that there may be some factor that we have to think about that's not related necessarily to local environment, right? Because we've taken somebody out of their normal environment to put them into Canada. But there was no real difference between the East and Southeast Asian. So I think that was really important. When you take a look at how patients did afterwards, what was interesting was the relapse rates actually varied quite dramatically, and that those who had frequently relapsing disease, remember I said that's only about 35% of our population, it was much higher among those who are of European descent than those who are South Asian or Southeast Asian descent. So maybe there's again, is this different that the disease is different in this group versus the difference among those in children who are European descent? And when we take a look at the absolute number of relapses, again, you could see 0 is here in dark, those who never relapsed again. And you can see that among the European South Asians and East Southeast Asians, that in fact, the South Asians had a much higher number, so did the East Asians, of never relapsing again. And this was statistically significant compared to the Europeans. But once you had frequently relapsing disease and we decided to give you a steroid sparing agent, you were no different. So to me, this really points to perhaps this group of patients who are here in the dark bars are different to this group of patients who are here. And again, as we just take a look at time to first relapse, we're able to show here that time to first relapse, there was a difference among the Europeans here in the blue, who had a higher rate of relapse compared to the South Asians and a lower rate among the East Southeast Asians. But again, after cyclophosphamide, really no difference. So I was interested in saying, well, let's go back to when a patient first presents, and can we actually take all the factors that we've seen, including ethnicity, and see if that can predict short and long-term outcomes? Because really what we want to know is, we don't want to wait the 46 weeks after they've gotten the steroids to then make a decision of are they steroid sensitive or steroid resistant and start doing the workup. We want to know when they first present, how should we actually be treating them? And so in a combination of patients that I had from the historical cohort, as well as our consented cohort, we had about 631 patients. Out of that group, we were able to follow them over time. And what we found is that in fact, there was no association. So what we did was, we took them, we followed them, and we were able to classify at all of these different time points. And just what's important to note is that we were able to see what was happening over time. It doubled the slide back. So what we took a look at was the combined cohort, all our insight, where we actually got very specific details on hematuria at baseline, allergies, prior infection, family history, low birth weight, baseline BMI, and we added all of these and we created multiple models. I had this great statistician and we did all multiple models, but in fact, it made no difference. No matter what we did, effectively, it was no better than flipping a coin. So when we see a patient, when they present with nephrotic syndrome, even though we clearly have some hints that there are differences. Nothing that we actually take can actually predict their long-term outcomes. And that's something that we think is quite important, because we don't want to just predict the first relapse. We want to predict what drug should you get. Are you going to be that 25% that never relapse again? Are you going to be that frequently relapsing? So we need to think about going straight to those kind of drugs. So again, when you think about the stratification, you want to think about well-characterized epidemiological studies. You want to consider categorization with intent, and really think about social determinants of health. So if we go back and we take a look, we now know that we've got these sort of nephrotic syndromes, steroid sensitive, steroid resistant. Some of them are treatment responsive or not treatment responsive. But what do we want to do for the steroid sensitive? So per our current guidelines, we have this flow chart of 12 years of age. You should evaluate them and think about a biopsy if they're greater than 12, and if they're less than 12, this is what you should do. Interestingly, age is not predictive. So this age 12 is really gestalt that's been there from older studies, but really not panning out in newer studies. Again, we want to see if they've been responsive or not responsive. And if they've been responsive, we start bucketing them. The problem is that these are significant overlap. And so even though the guidelines sort of look clear, they're not so clear, because the children still overlap at different times. And so we need to be really clear about how we're going to follow patients. And so we took our cohort of 631 and we were able to say 162 did really well, 268 were infrequently relapsing, and it's only a very small number that we have that progressed to end-stage kidney disease. So how can we predict who these people are? How can we predict who these people are right over here when we first see patients? So I think what we should be thinking about is these endophenotypes. So we now think steroid resistant, steroid sensitive, and steroid sensitive, there's this group that only have a single episode, those that have very few relapses, those that relapse a lot. And there is a group that are progressive that go to end stage, but this is quite a small number. So how can we think about these four groups a little bit differently? So what I'm hoping is that as we break down these endophenotypes, that we'll start looking at host genetics and saying, perhaps host genetics can actually help us tease out those differences. Because remember, those who never relapse again, or those who only are infrequently relapsing, the only thing that's there is a risk factor, because we looked at all the other risk factors clinically, not everything, but it's either a circulating factor, it's your host genetics, right? It's your germline genetics. And so what's been interesting is a number of GWASs have come out. I'm not going to go over the GWASs for other types of kidney disease, but a similar theme is arising in that HLA keeps coming up as definitely a marker, a genetic risk factor for the development of nephrotic syndrome. There are another couple of genes that have been found, but they're not consistent among different studies. So we think that in fact, this immune-mediated glomerular injury that we get that leads to both minimal change disease and FSGS involves the interaction of the genetic risk loci with some other environmental factor, perhaps infection. What's also been seen here among the European study is that they took 722 children with steroid-sensitive nephrotic syndrome. They were able to GWAS in the number of cases compared to controls, and this is using the UK Biobank, and they were able to identify the HLA locus. And again, HLA locus varies in, slightly by different ethnicities, but they were able to then identify these two other variants. Unfortunately, those variants have not been replicated in other studies. Then if you take a look at a study done in Asia, among those from Japan from a genome-wide association study, then when they said, let's include others from other transethnic meta-analysis, they were again able to find a single gene, NPHS1, which is an apodocyte, again associated, however, it wasn't replicated in every study. And again, the HLA locus comes up. This was a study that's still in MedRex, but I just wanted to show it here from Matt Sampson. Again, taking a larger population, now 2,400 cases, so doing a meta-analysis of already published data, taking those groups, and again, trying to identify what specific loci are actually relevant. Again, the HLA DQB1 came. Perhaps these other genes have also been associated, but it may be pushed by these different sort of cohorts that they were found in, and a number of other variants were found. But consistently, HLA keeps coming up. So I think what we're thinking about is now that you're host and environment, and you have these disease modifiers that probably impact whether you're going to be in one of these 4 groups. And what we've also learned is that there are some Mendelian disorders too. So these are quite rare, but there are known genes that are associated with Mendelian forms of steroid-sensitive nephrotic syndrome. And so what's important is that these are potentially genes that, again, might help us identify what we might find in the GWAS. For example, NPHS1 was associated in the rare family. And so again, we're discovering more genes in these rare sort of families with multiple probands having kidney disease. But what's interesting is that none of these genes are consistent between this and what we find in the genome-wide association studies, but we're getting closer. So what I think is actually that it's an evolving paradigm, that I think that steroid-resistant disease is now that you've got Mendelian disease here, you have Mendelian disease that can cause steroid-sensitive disease, but perhaps this group is actually a group that we still haven't teased out completely, but they're different in that you have the single episode, the infrequently relapsing, the progression, then stage renal disease, and those who are treatment responsive but also progress really quickly. What I can't show here because we're recording the talk is that we've done an insight GWAS also, and specifically have taken a look at this population and have been able to identify HLA loci that are able to help differentiate which groups. So we're looking at ethnic specific because we think that the differences by ethnicity. We're showing it among the different ethnicities overall. And then the idea is that we're looking at the specific outcomes so we can actually show that they're associated with the specific outcomes. So no longer are we just here with the GWASs. The idea is that we're actually going to do a GWAS here. And right now we're just doing the validation steps so we can understand association with outcome. What we also know is when you take a look at HLA and you take a look at the kidney cell itself, what's really important to understand is that there's actually these trigger events that occur and they affect the antigen presenting cells. You have this HLA locus, differs from ethnicity to ethnicity, but in fact trigger a B cell or T cell response. It looks like it's predominantly a T cell response, but there are clearly some cases that respond to rituximab. And we also believe that there's some circulating factors that are associated. And so what we need to understand is perhaps if we can differentiate a T cell mediated nephrotic syndrome versus a B cell mediated nephrotic syndrome, maybe in that way we can start teasing this out so we can start directing therapy. And this is just to show you that there are many circulating factors, that there are some other ones that are talking about looking at the glycocalyx within the cell itself, taking a look at some other permeability factors that have been described in Wisconsin in a patient when you take a look at their plasma and they're able to change the conformation of glomerulus. It's also being SUPAR, which is released from the vascular endothelium, also being thought to be associated with nephrotic syndrome, but now shown to be ubiquitous, related to cardiovascular disease as well as all different types of kidney disease. But there is one that I think is quite interesting, and that just came out last year from Astrid Wine's lab in BI in Boston. And I think what's interesting is that she was able to take specifically nephrin autoantibodies that were generated, take a look at healthy participants, take a look at 62 children and adults with minimal change disease, and also take a look at an antibody that's seen in membranous. And what she was able to show that in fact, that there was a significant, a logarithmic rise in the anti-nephrin antibodies. And what she was able to show within a small group of the patients that she had samples for that were active or in remission, that there were clearly differences in the autoantibodies that presented. And what I think really interesting was that she was also able to show that there was evidence of the nephrin antibody locally within the glomerulus itself, which is great, and being able to show it that it co-localized with synaptopodin, which is a potassium gene. What was also interesting was being able to show that it was IgG positive biopsies in 9 patients with minimal change disease, and that there was IgG negative in the biopsy controls. And again, she was able to take a look at the different cell types. And so I think what's interesting with this is that it's really provocative to then go back and say, well, maybe what we need to do is really think about the podocyte genes themselves, and what are all those autoantibodies that could be generated? And is there a link between the HLA and the autoantibodies that we could actually start being able to direct different therapy? So right now what we're doing is we're working with Astrid to be able to do this within our insight cohort so we can actually start targeting specific patients and to see if we can elucidate exactly what's leading to disease. So again, do you have rapidly progressive disease? Do you have a treatment responsive disease? Do you have Mendelian or complex disorders? Do you have an adaptive immune response, or do you have autoantibodies or circulating factors? And what's your underlying host genetics? And so this is sort of what I keep thinking about as I sort of try to think, how could we break this bucket down to make it much easier? Because ultimately, we want to target each one of these individual groups completely differently and actually make a focus for, make a target that we can actually treat the children. And so we can get better than the 1957 shotgun approach with steroids. So that's really what our hope is, that you present here. We perhaps don't give you steroids to understand this, but my hope is that we can already predict where you're going to be so that we can understand where we need to move people to. So I'm just going to also just show you quickly, when you see children who are frequently relapsing, it's important to note that we sort of go through this cycle of what patients go through. And I think what I'm trying to say is, can we at this point prevent this sort of both not a diagnostic oddity, but a treatment odyssey, and sort of try to get rid of this whole cycle and cascade that we do? And it's pretty consistent. Some places treat differently. Some people start straight with Mefortic or rituximab. This is sort of our regimen. I don't think that any place is perfect. And so there's no perfect way to do it. But I think what we need to do is understand how to better treat our patients. What's also interesting is when you take a look at 5-year outcomes. So most of our studies within pediatric nephrology tend to be 1 year, time to first relapse in the first year and the first 18 months. But if you take patients and you say, what happens over 5 years? What's very interesting is that if you take the different drugs, so cyclophosphamide is in the dark blue, and you can see, in fact, in the cyclophosphamide, like 25% of them are never going to relapse again. In tacrolimus, it's probably about 18% are never going to relapse again. But with the mycophenolate and the rituximab, they're going to relapse much faster. And so their long-term survival is not as good. And even though the sample size is super small, we're going to keep looking at this every year so we can get larger numbers. But I think one of the things we haven't taken a look at again is, how do children do down the road? Because what we're not interested in is just treating this first year. What we want to do is understand what happens over time. And we want to know how we can treat them to get to cure. How can we get to long-term remission? And so I'm working with Cal Robinson, who's a PhD student with me. He's a pediatric nephrologist. And our goal is to do some target trial emulation. And so what we're going to do is take the data that we have. We're hoping to also take data from CureGN. We're going to take a look at it together. We're going to ask some clinical comparativeness questions about those different drugs. But what we're hoping to do is add genetics and biomarkers. And once we add that, my hope is we're actually able to say, you have this genetic and anti-nephrin antibody, and you will respond to cyclophosphamide. You have no antibody, you should get tacrolimus. And ultimately, I'm hoping within the next year or two that we're able to actually show the data and be able to try and do biomarker guided studies. And so this is what I'm hoping for nephrotic syndrome, so that we start doing this deep phenotyping, integrate biomarkers into clinical trials, and then start individualizing our strategy as we go into treatment. And our goal should be long-term remission, not just time to first relapse. Ultimately, these, just so you know, are called basket trials. Also, you can set up this platform and do a platform trial. And the idea is that you're actually able to manage your patients using standard of care. As drugs come up, you can start with treatment 2 and see what happens compared to standard of care, and then give treatment 3, and that could be dropped due to futility. And hopefully we can now add biomarkers to that so we can start guiding the therapy. And that's our goal within the next couple of years. So just to give you a summary of what we've done so far. So the HLA locus is important for steroid-sensitive nephrotic syndrome. No GWAS conducted yet with longitudinal outcomes, but hopefully we'll be publishing soon. The genetic panel should be broad and screen all individuals regardless of genetic ancestry. And we need to further assess serological and urinary biomarkers to tease out these endophenotypes. And again, I've talked about integration of more data so that we can be really precise in how we prescribe our medication. I'm going to move now to steroid-resistant nephrotic syndrome, in that this is about 10% of the population that we see. And what's important is that when people take a look at like our FSGS patient or steroid resistant, when you biopsy them, a lot of them have evidence of FSGS. And what's concerning about that is that the rapid decline that they can go to end-stage kidney disease compared to other types of kidney disease. And our goal ultimately is to shift this curve for as long as possible because the mortality rate is so high on dialysis. And patients really progress, and so our goal is really to understand this disease a little bit more. What's important is that there are already known genes. These are all the Mendelian genes that I was sort of talking about before that are associated with steroid-resistant nephrotic syndrome. And what's important to realize is that there are many genes. There are probably going to be at least 20 or 30 more. There are over 80 so far. And when we do genetic panels, it's important that that panel get updated regularly on a yearly basis because we continue to find more and more genes that are associated with these rare diseases and families that occur. But when you take a look at those who are supposed to have genetic steroid resistance versus familial versus sporadic resistant or compared to steroid sensitive, not surprisingly, the steroid sensitive do quite well from a kidney survival sort of point of view. But those going to end-stage renal disease, if you have a known genetic disorder, you rapidly progress. But what I thought was interesting is that there are these two groups here that clearly must have something else that's going on. They're both steroid resistant and they're also familial here in the black, but they don't progress as fast as known genetics. So the question is, what is there something else and some other disease modifier that's accounting for that? This is sort of the IPNA guidelines on steroid resistant. And I think part of this, I don't expect you to read this, but part of seeing all this messiness is we're still not so clear. And what we really need to do is understand the disease much better. Because I think what happens is this is confusing. We're not sure who these people are and what they have that leads to disease and how we should treat them. And therefore we go through this every single time. We try serial drugs, serial therapy to see if in any way we could potentially see if there's anything to salvage. So when you take a look at steroid resistant, you think simply that they didn't respond, but sometimes they're treatment responsive. So I think this treatment responsive group should move down here, and we should really start thinking about this group. But there's also the need to understand, once you've worked out the genetic causes, what are the other things that could potentially lead to progressive kidney disease? Oh, I'm sorry, some of my slides duplicated. Oh, I went backwards by accident. All right. So just going back to this gamish that there was just, it's too complicated. So we need to tease this out. What we need to tease out is who's going to respond to therapy in the steroid resistant and then who's rapidly progressive. And so again, going back to really thinking about social determinants of health, can we actually break people down? Are there some demographics that could be associated with it? Are there differences in disease in different ethnicities? It's important to note that end-stage renal disease, including children, when stratified by race, that there's much higher prevalence of end-stage kidney disease in African Americans, 3.4 times greater prevalence than those that are of European descent. Native Americans have a higher prevalence too, so do Asians, but not as high as African Americans. And what's been interesting is with the access to healthcare, with better healthcare over time, it has come down a little bit, but we clearly haven't reduced all the disparity that occurs in kidney disease. We also know from a study among the adults, an African-American study of kidney disease that basically said, let's actually manage your blood pressure really well, intensive blood pressure control with an ACE inhibitor, and that should be better than what's currently standardly given. And what they were able to show in the trial phase of that is that you were able to compare those with intensive therapy versus standard therapy. And you could see, in fact, that those that had received intensive therapy, that the incidence of kidney disease was much lower. So what happened was everybody in the trial at the end of 3 years, it actually got stopped early, showed that there was a benefit to intensive blood pressure control and being on an ACE inhibitor. So everyone got converted, and ultimately they were converted then into an ACE inhibitor and intensive blood pressure control. But you can see as you follow patients over time, up to 10 years now, in sort of this observational phase after the randomized controlled clinical trial, that there was relentless progression despite adequate blood pressure management. And so that's really important. So even though we were seeing patients, they were in a trial, they should have been doing much better because we saw them in a trial, they were in fact progressing much, much faster. And those patients who had significant proteinuria in this upper arm, again, would progress even faster. So there's clearly something about beyond your blood pressure control, managing your proteinuria, exactly what could we do to actually understand that a little bit more. And so when you take a look at kidney disease, that there's clustering of kidney disease in families, we talked about in nephrotic syndrome and FSGS, but also in other types of kidney disease. But what's really interesting is that if you have a family history of someone with end-stage renal disease in the family, it increases the risk twofold overall, but it's fivefold higher among those who are African American. And what we also know is that globally, that in fact the incidence within Africa varies, but sub-Saharan Africa has a higher incidence of FSGS, minimal change disease, and also within the United States, it's been shown a higher incidence of FSGS. So going back to thinking about nephrotic syndrome, a small proportion of our population have steroid-resistant disease. FSGS is super common, but really common among those of African ancestry. And so as we're trying to understand the disease and trying to partition it, what's really important, I'm just gonna step back for 1 second, is I wanna talk about making sure that when we talk about this race-based medicine, that was really, we're trying to understand links with race and disease, but trying to understand if there was potentially a biological difference, but using race quite crudely. And what's really important is that we really think much more about race-conscious medicine, that we're trying to understand within a group, just like the way we studied among those who've got hypertension, we looked among African Americans and there was still progression of disease. So perhaps that sort of lends credence that perhaps there's some biological differences. What's also important is terminology has changed over time. And so I'm going to describe some studies that were older, and they typically would talk about self-described ethnicity, and we talked about African Americans. But what I'm really trying to get to is I'm really trying to talk about ancestry. And I think that was something that we were able to tease out with clear epidemiological studies in the US with data and cohorts that were older. But as we move forward, I think it's really important that we make sure we use the right terminology. And the reason I talk about that is that often people conflate genetic ancestry and race. And I think it's really important that we recognize that as I've talked about genes might occur in the South Asian population slightly differently than the European population, but we all share the same genes. What we're trying to do is understand those minor differences that may actually lead to disease differences that can help us understand mechanism. And so we are all 99.1% exactly the same. And so it's important for us to recognize that we're just trying to tease out these differences and these differences between groups a little bit to say, is there something that can hint towards the pathogenesis of getting disease? But we're not trying to identify and say that we're all different, because hopefully we all share that same mechanism. And so while at Hopkins in 2000, I worked closely with Linda Cow, my collaborator, and we were working on a study called FIND, where we were actually recruiting based on the work that had been done so far at Hopkins to show that among the African American community, there was this relentless progression to end-stage renal disease and a very high odds of having kidney disease if you had a family member. And so the idea with the hypothesis was that there was something on the African genome coming from West Africa that as you then had admixture with the Europeans, it generated the African American population. And so we needed to understand what was there on the African genome. So an admixture creates a mosaic. So you have 2 African chromosomes, 2 European chromosomes, and then you get this admixture over time. And the black is where the gene of interest is, and 3 generations ago, you keep going down and you can see that the breaks happen and then it gets passed on. And so now what we're looking at is this population, and what we're trying to understand is what's in the yellow in the African genome that contributed to end-stage kidney disease. And what we published then was looking at the chromosome 22 locus that was associated with the development of end-stage kidney disease among African Americans. A number of groups at the same time had also reported it. And what we took a look at was this region that was in the African genome that basically said, these are all the genes that are in that area. And we focused down on MYH9 because there was Mendelian disease. But in fact, 2 years later, the 1,000 genome data came out and people were able to identify it for APOL1. And so what's important is that in this discovery of the chromosomal locus, we were able to then target on focus on APOL1 and be able to try and understand how does it cause kidney disease. So there are 2 haplotypes for APOL1, G1 and G2. APOL1 is bound to HDL and circulates. In fact, it helps transport HDL in the blood. It occurs in humans and some non-human primates, which makes it hard to study because it doesn't occur commonly in sort of mice or rats. And APOL1 protects against sleeping sickness. So that was very plausible in that it protects against infection. So you have no risk alleles. You carry normal APOL1, you get sleeping sickness. If you have one of these abnormal alleles, G1, for example, you won't get sleeping sickness. So there's a heterozygous advantage. But if you get two risk alleles, what will happen is that you won't get sleeping sickness, but you get chronic kidney disease. And so there's a homozygous disadvantage. And so it's very much like thinking about analogous to sickle cell disease, where you then think about sickle cell, you get an acute crisis, it's autosomal recessive, it has complete penetrance, the trait is rarely at risk, you're at risk if you've got two variants, but it's not that common, and it's uncommon also among European Americans. APOL1 on the other side, it's a progressive disease, so it's not an acute crisis. It is autosomal recessive, but the penetrance is clearly variable. And this is really the part that we need to sort out. Those who are one variant don't look like they're at risk at all. And if you've got two variants, you're at risk of progression. It protects against sleeping sickness, but sleeping sickness is not very common now, hasn't been common for a while. And so the question is does it infer other things besides sleeping sickness? And it's extremely common if you look at it compared to sickle cell disease. So 1 in 10 are walking around with at least one variant of APOL1, and yet they don't have kidney disease. So we need to understand a little bit further. And it's got a low prevalence among those of European ancestry. Without showing you all the studies, what's been really interesting is that we've been able to show in multiple different published studies that there's an association across the lifespan. Association in utero also with women who are preeclamptic and with babies. APOL1 status actually infers higher risk for preeclampsia, which is interesting. We're doing a lot of work with that within Africa. Young children who also have high blood pressure, or those who've got FSGS. And so what's important is that this gene is being associated with FSGS and causing the scarring, and perhaps this population you get FSGS, or you get FSGS and HIV disease or sickle cell disease. These are the populations that are most interesting, I think, because they're at the greatest risk of progression. Once you discover something, the issue is that when you're now doing it in lots of different studies, you have to recognize that there's regression to the mean that occurs. And so also called Wiener's curves, right? So you think that you're going to have something and it's this great association, but depending on what type of study you do, there's definitely some attenuation. So all the studies that are cross-sectional or case controlled have shown this really high odds ratio of 2 to 28. But when you take a look at the very few longitudinal studies, the risk is actually much lower. So it doesn't mean that APOL is not significant. It just means that how it's associated, perhaps a little bit lower risk. And so it's important for us to understand that it's a little bit lower risk, and clearly there has to be some environmental interaction. In children, just so you know, these are the studies that have been done in those with kidney disease. And this is just a review, but you could see that those who carried the high risk alleles, carrying 1 or 2, actually vary quite dramatically depending on the population, whether it was a population in the United States, a population in Africa, a population in Birmingham, and a population in Europe. And so it's important to recognize that it does vary from place to place. So because of that variability, we're working on understanding APOL1 within Africa. And what can be learned? Well, a lot can be learned, I think, because the African populations actually harbor the greatest human genetic diversity following evolutionary history. And so there's a ton that we can learn. The signatures of selection from environments, cultural practices, epidemics, migration, all of them are incredibly important for us to understand. And it'll really help us understand APOL1 throughout the continent. So this is just, this was published last year, and this was from the H3 Africa group. I'm part of the kidney disease group. And so this was the geneticists from each group who published this. And what I think is important is to recognize that samples and participants were collected from all over the continent. But when you take a look at something called principal component, you're trying to understand how do you actually differentiate different groups by taking a look at their genetic ancestry. And we cluster people by principal components. So this is a vector analysis. And we basically say, how can we cluster people that come from Europe, people that come from different parts of Africa, different parts of Asia? And what was really interesting was there was a lot more homogeneity among the West Africans compared to the South Africans, and a huge amount of variability in Central and East Africa. And that's really important to understand because in fact, there was a migration that occurred from West Africa. As you were coming down, it's called the Bantu expansion. And what happened was that there was migration that occurred from West Africa into Central Africa, and then from Central Africa up into East Africa. And because of that, the APOL1 distribution is quite different within the continent. When you take a look at the kidney disease group that we actually take a look at, we're concentrated in this area. And what we're doing right now is trying to understand for the kidney disease network where the disease prevalence is. And we also have data available from other cohorts that have been collected across. So within H3 Africa, one group that are based in South Africa took 10,000 patients across the continent, and we were able to show that those that carried 2 APOL1 alleles were about 7%, and so in the general population, relatively low. In the 5,000 patients that we have, when we took a look at it in those with kidney disease, you could see that the prevalence was much higher. If you take a look at it again in the general population, relatively low. But if you take a look at it, this is an HIV population, you can see that in fact the prevalence was also relatively low compared to those in kidney disease. So it's interesting that depending on the cohort you study, the prevalence actually varies quite a lot. What's also important is when you take a look at the risk now, what's the odds of having odds ratio of APOL1 associated with kidney disease? You can see that in the general population that the odds were quite low, quite modest, I would say. Similarly, in those in the kidney cohort, a little bit higher in those who are, again, this was HIV disease and chronic kidney disease. And what was interesting among those who had HIV disease with albuminuria in children was actually quite high. So even in children, there's a significant association, but maybe the issue is that the environment with HIV is actually the environment interaction that you need to have progressive kidney disease. And I'm just showing you this just to show that as you go down from different types of studies and you take a look at the association, it's much worse in those in HIV. And as you go progressively down to different types of chronic kidney disease, you can see that in fact, the risk attenuates. And then the odds for progression, there are very few studies longitudinally and none within Africa. So we have a lot to do in order for us to be able to understand more about APOL1 and long-term risk. What we do know though is that the mouse models now can recapitulate kidney disease by causing proteinuria. We know that there's difference in the G1 versus the G2 allele, but we know that there's incomplete penetrance, and that also happens in mice. So there's clearly lots of conditions that we need to try and mimic in order to try and understand what's the stress that you're under in order to actually develop this APOL1 related disease. The mechanisms leading to disease, I won't go over this in detail, but there's just a number of them. One of the ones that I'm going to show you now a little bit more is that there's now a drug that affects APOL1 here going through the pore. And this is actually the mechanism of how it affects sleeping sickness, but APOL1 actually opens the pore through endocytosis, enters into a cell and causes lysis. So this was just published actually this week. It was from Vertex, and axolotl is actually the drug that was called VX147. And it was actually designed by Vertex to cause selective inhibition of the APOL1 channel function itself. And what I think is important is that this is how they think it works, and that it's an oligomer that actually then attaches here to the channel itself, preventing aberrant ion flux and osmolysis. And what was interesting in just 13 patients, one had an increase in the protein, but 12 of them had a decrease in the protein. Overall, it was a 47% reduction. And you can see that it was about the same in those who had either a nephrotic range or subnephrotic range. And what was great was to see that there was significant effect up to 13 weeks. This is currently in a phase 3 clinical trial. So lots more to find out. Sadly, I haven't been able to convince them to include children, but my hope is that within the next few years, we'll be able to give this to children at least above 16. There's a number of trials going on for APOL1. It's exciting. I think it's really important. Again, what we're trying to do in kidney disease is, can we actually do biomarker guided trials so that we can actually target specific pathways? And that might be the best way for us to be able to aggregate kidney disease. But what's important to note is that it isn't just those from African ancestry and only those predominantly from West Africa, but because of the slave trade that happened, more than 12 million Africans were enslaved and forced migration across the Americas. And so it's important to recognize that the prevalence basically is based on the patterns of the slave trade. And so you can see that, in fact, the higher incidence when you take a look at 1,000 genome data is high within West Africa and Nigeria, but it's also high in Salvador as well as the Caribbean islands, including the United States. And so this is an important thing to understand, is that when we try now to understand ethnicity in disease, and we're going to think about measuring APOL1, we have to try and understand, well, how are we going to do that by ethnicity, or perhaps we should be testing everyone. And the argument I would make is let's test everybody, because even in the United States, when you take a look at cross-sectional studies among Hispanic and Latino populations, that the percent of those that have evidence of APOL1 is actually quite high, but their ethnicity may vary. And so what's important is that it's really important for us to understand that population and recognize that APOL1 was as high as 6% in diabetic end-stage renal disease and 20% in New York City, but much lower in Caribbean mainland and the study of Latinos. So you can't tell who's going to have APOL1. And within the United States, there's so much mixture that it's really important that we think about this variability. And so genetic ancestry varies greatly. And what's important here is that the mean African ancestry varies again, or where you live in the United States. And you can also see that those who self-report as African Americans, there's a lot of Native American ancestry. And so that's incredibly important to think about. And when we talk about change, we're talking about multiracial Americans are really driving change in the US. And so what I would say is here, sort of thinking about Pittsburgh, it's important to recognize that perhaps we shouldn't be doing things thinking about your skin color and thinking about race, but in fact, thinking about really how can we actually measure that more globally. And my hope is I've convinced you that for this and for some other genes, we should not think about ethnic specific, but really think about we as much as possible. People are getting genetic testing, and APOL1 offers this service, and you can actually get it on sale for $159 if you like. So it's important for us to think about this, as this is now direct consumer marketing, and we need to make sure that we understand that if patients come to us with APOL1 measure. So my hope is that I've taken you quickly through thinking about how we traditionally manage patients, but how we're thinking about how we should get better about stratification. And ultimately, how do we get to position is really how do we incorporate all of this information. And I just use this example from heart disease because it's the easiest to explain. We know that there are clinical factors that predict clinical risk. We now know that perhaps there are multiple genes that can explain polygenic risk. And if you're up here, plus these, then we're now understanding what's your clinical risk and your high polygenic risk. And hopefully then that's a marker that then we can use when you first present to actually screen for kidney disease. And one study just taking a look at Christoph Kurlik did a polygenic risk score. And without going into too much detail, he was able to look at the African ancestry, those who had Latinx, admixed ancestry, and he was able to show that those who carried APOL1 were at high risk of kidney disease, not surprisingly. But if you were at the polygenic risk score that was very high, without APOL1, your risk was there. But if you had a polygenic risk score and your APOL1, in fact, your risk was much, much higher. And so you can see it graphically here. So looking at the different quartiles of your polygenic risk score, if you had the highest quartile and you had APOL1, you were at the highest risk. And so APOL1 still is significant, including a polygenic risk. So it's important to understand those two things. So I think we're kind of here, at least I'm hoping to push people here, is that I think we should think about rapidly progressive disease, think about Mendelian forms of disease, think about complex forms like APOL1 that leads to rapid progression. And maybe this is a modifier gene. If you have treatment responsive nephrotic syndrome, my hope is ultimately we get to what's your adaptive immune response with your HLA. Do you also have autoantibodies that are circulating? And then do you actually have other complex genes that may be contributing? And then what are your host factors that can actually contribute? So it's important to know APOL1 is a gene for progression. I think we should really be more inclusive about how we approach it and screen all persons with FSGS, for example, for APOL1. I think it's important because now we can actually treat the disease potentially. So this is really important for us to know. And I think that we need longitudinal studies and more studies in children to understand the relevance for it. And so if we go back quickly to my patient, I think it's important that we do genetic risk. We understand what those factors are. We think about treating them, potentially APOL1 directed therapy. And my hope is that, in fact, of just giving them tacrolimus, we'll actually have biomarkers to target further therapy. I'll quickly end here, actually, because of time. I went a little bit over. My goal is for us to be here and provide precision medicine. Thank you very much.
Thank you. That was fascinating and really eye-opening in terms of potentials and exciting about future research in that area. And also, thank you for the thoughtfulness on race and ethnicity and genetics. Very much appreciated. So I think we're at the hour here, and we'll end our formal grand rounds and transition to our meet and greet. I know we have a couple of questions from the audience, but if there's a question here from the virtual audience, I know we have two questions, but if there's a question here, we can start with the audience in person. And again, thank you to Dr. Ellis, who is here in person, for being here and for inspiring this lecture series.
Thank you, and my apologies. I didn't realize I had gone over so long. My apologies.
Do you have a question that you want to ask first, Jackie? I know that you had, yep, or Dr. Ellis.
Well, I just want to take, first of all, the opportunity to congratulate you for all the progress you have made since we first met a number of years ago. You have extended so much to our field, the information that we have. It's always important to know what causes a problem before you find the solution to the problem. And you used nephrotic syndrome as a model or perhaps prototype of a condition that is really not a single disorder, but with a lot of endophenotypes or difference in treatment and response. Where do you think we are going with the treatment aspect of this? How can we extend the translational studies to better manage the condition and to limit side effects?
So I'm hoping that we'll have some preliminary data to help us guide some of the genetics, to help guide some of the medications. So I'm hoping with Cal, the PhD student, that we're going to take our insight cohort, our genetic data, and we're going to test it with drugs and actually say, if you carry this gene and you get this drug, what's the outcome? Because clearly not everybody with cyclophosphamide responds. So perhaps there are differences, so that we're hoping to look at those differences so that we can understand that. So that's really my hope, is to spend a lot of time trying to dissect those pathways using genetics and hopefully the autoantibody. Because I think the patients that get rituximab finally in our pathway, I think they get rituximab because they probably have circulating antibodies that they've been generating. We don't know what's that trigger for the antibodies, but I think that's why those kids fail multiple other therapies. Because we actually need to, where some of them have a T cell mediated disease, some of them have a B cell mediated disease, and we need to probably figure out who has that and start giving them rituximab early. But not everybody should get rituximab, because 25% only have one course, like only get steroids once. So I think my hope is to really use the genetics to help identify those 4 groups and then start teasing out with drugs. So my hope is in the next 2 years, we'll have a lot more data to be able to show that difference. I think that if I could just make a plug, I think one of the things that's happened is jumping to GWAS studies. All the GWAS studies are across our case control, and they're looking at children just once, but they don't look at longitudinal outcomes. And I think part of our issue is the studies take that big bucket and look at everybody. We actually need to parse it out and really be clear about the outcomes that happen to people.
Thanks so much, Rulan, for that really inspiring talk kind of and thinking about where we're at in our treatment of nephrotic syndrome. I wondered, it looks like there is a signal for the HLA subtypes. Do you have a sense at this point, how much of a risk factor that is likely to be? And it might be too early to tell, but.
I actually think it's going to be the biggest risk factor that we end up having among all the cohorts because it's consistent. I think it'll vary by ethnicity. And I think what we're going to have to understand is we've got it down to a protein level. And my hope is that if we can understand it at a protein level, where it affects, and we think it affects T cell function. So now what we're going to do is try and take a look at some markers and of T cell function and see if we can tease that out a little bit more. But in rheumatoid arthritis, they do something really interesting is that they found a similar marker, but they're able to show that you can have that HLA, let's say locus, but you also develop an autoantibody. And it's that combination that gives you the worsening progressive disease. But some people only have the HLA, but everybody else has HLA plus the autoantibody. And so there must be a trigger for that autoantibody. And so that's what we need to try and sort out. So I think that's the way we should be going, I think, and try and think about it like that, similar to the lupus patients and the rheumatological diseases, because they also have a significant HLA locus, and then are also looking at circulating factors.
Thank you.
Yes, I have many questions, but it's a sociological question that I have. We are amassing all this genetic data about apolipoprotein 1 and its contribution to the progression of kidney disease in many conditions, not just nephrotic syndrome, but hypertension and other disorders. Although attempts may be made to safeguard all this information regarding the patients and perhaps their families who may be screened for APOL1, there are always unintended consequences where health insurance companies, for instance, might get access to the information and not permit insurance, health insurance, which may not have an issue with Canada because of socialized medicine. But in the US, where medical care is very expensive and disproportionately affects the African American population, having such data get into their own hands, the insurance companies, for instance, that fund healthcare, that could be counterproductive, perhaps. You have some.
Yeah, I have a lot of opinions on this. I think that I was probably the most skeptical about genetic testing everybody for APOL1 because I was concerned about there's both stigmatization that can happen, discrimination that can happen, and denial of healthcare or other types of insurance that you could get. And there was a young woman we had at one of the a National Kidney Foundation working group panel on genetics and genetic testing, and it's not out yet, but she said, I'm in medical school and you've tested me for APOL1 because my mother's on dialysis. And I now can't donate to my mother who may die. And now I don't know if I'm going to get kidney disease. And yet you can't give me any information about it because you don't know yet. So why did you do the test if it wasn't going to change? And why, and you still can't tell me that I can't really donate to my mom because you don't know if I'm going to be okay yet. And that was really moving to me because I thought we have to be so careful about when we take genetic testing into clinical realms. And as pediatricians, we think about it a lot because we see so many Mendelian disorders and familial disorders. But there is this issue with APOL1 that we have to think about very carefully. And it is extremely common. And so I think that we have to do those studies to understand how do people feel about the stigma? What are we going to do about it? And when should we do it? So from a transplant perspective, with the Apollo study, I didn't get into that today, but the Apollo study will ultimately give us some information. But I suspect, given the absolute incidence rates being so low among donors, I don't think it's going to change that much. And I think that, I think what we need to think about is where should you do the testing? I think FSGS, to me, is the best place to do the testing. We know that it can be a disease modifier. We now have a drug for it. We think it could be effective. Let's see what the trials come out, but that's the population that we already screen for genetic disorders. So to prevent them getting toxicities from medication, that to me is a more cleaner indication than doing testing for everybody who sort of walks in the door.
Thank you. That you could have a whole talk on that, I think. Yeah, very provocative and important to think about.